Welcome back. So, you need to get up to speed on gestational diabetes mellitus, GDM,
You
fast.
get it.
And it's more than just, blood sugar numbers. It's really a fascinating look at how pregnancy just completely changes the body's metabolic rules.
Yeah, our sources show this picture of the body doing this major, usually beneficial overhaul.
Right. But sometimes that same process just kind of speeds up too much for the mother's system to handle.
Exactly. And that's our mission today. We want to unpack those big hormonal and metabolic shifts
Figure out how that leads to GDM.
and, crucially,
Mm.
give you the key clinical facts, diagnosis, management, which you really need to know.
Okay, so we're looking at two main things interacting: how the body uses energy metabolism, and then the control center, the endocrine system, using hormones to direct all that.
Fine.
Let's kick off with the changes in a healthy pregnancy. I mean, most people know the uterus carries the baby, but it becomes, along with the placenta, a major endocrine player, right?
Right.
Like a hormone factory.
A powerhouse, really. It's a huge shift. The placenta starts pumping out progesterone, estrogens, HCG, and really critical for GDM, human placental lactogen, HPO.
Wow.
And these aren't small tweaks.
Okay.
They change the mother's whole system. Her basal metabolic rate goes up, how her kidneys work. Everything adapts.
So what's the ultimate point of all this hormonal chaos? Why does the body bother?
It's all about the baby, supporting fetal growth.
Yeah.
So early on, the mother actually stores more fat, getting ready for the energy demands later.
Makes sense.
Her lipid metabolism changes too. You see higher triglycerides, higher cholesterol. But the ingenious part is the increase in insulin resistance.
Wait, the body intentionally becomes resistant to its own insulin? That sounds bad.
It does sound counterintuitive, yeah. But it's strategic.
Strategic how?
It's about prioritizing the fetus. See, if the mother's tissues are a bit resistant to insulin, they don't soak up as much glucose from her blood. And since glucose crosses the placenta easily, but insulin doesn't, this resistance means more glucose gets, well, shunted directly to the baby. It's like directing traffic. Feed the baby first.
Huh. So normal late pregnancy is already kind of pre-diabetic by design.
In a way, yes. It's a physiological state geared for fetal benefit.
Okay, so that's the baseline. Where does GDM come in then? When does it tip over?
GDM happens when that normal, helpful resistance just gets pushed too far. It becomes extreme pathological.
And what pushes it? Still those placental hormones.
Exactly. It's that same team, HPL, estrogen, progesterone, cortisol acting together,
Right.
but they really ramp up the resistance dramatically.
So the issue isn't the hormones themselves, but the mother's body trying to cope.
Right. The problem is that her pancreas, which is already working harder, just can't produce enough extra insulin to overcome that extreme resistance.
It can't keep up with the demand.
Precisely. And that failure to compensate leads to high blood sugar in the mother maternal hyperglycemia, that's GDM, usually kicking in around 24 weeks.
And that excess sugar, it just flows across the placenta to the baby.
It does. And the baby's system reacts. The fetal pancreas starts working overtime, pumping out loads of its own insulin.
Okay.
We call that fetal hyperinsulinemia, high fetal insulin. And you really need to remember that term because almost all the immediate problems for the baby stem from this.
Kind of amazing, though, how fast things can snap back after delivery.
Oh, it's immediate. The moment the placenta is delivered, poof, the source of those resistance hormones is gone.
So the insulin resistance just plummets.
Drops rapidly. Often the mother's blood sugar normalizes within hours, but that period of instability, even if temporary, it does leave a mark metabolically.
Okay, let's shift to the clinical side then. If you're learning about this, how do we actually diagnose GDM? What's the process?
Standard practice is screening between 24 and 28 weeks.
Mm-hmm.
It starts with a glucose challenge test, just a screening test.
And if that comes back high?
Then you move to the diagnostic test, the 3-hour oral glucose tolerance test, the OGTT. And for a GDM diagnosis, you need 2 or more abnormally high blood sugar readings during that 3-hour test. We might also check an A1C, to get a sense of longer-term control before or early in pregnancy.
Once someone's diagnosed, the management seems to come in stages. Can you break down A1 GDM versus A2 GDM?
Sure. A1 GDM just means it can be managed with lifestyle changes, so diet and exercise.
What kind of diet?
Usually a balanced, carb-controlled diet, often focusing on low glycemic foods, plus consistent, moderate exercise, like 30 minutes of walking after meals is often recommended. It helps improve insulin sensitivity.
Okay, simple enough. But if diet and exercise aren't cutting it?
Then we move to A2 GDM. That means medications are needed.
What kind of meds?
Well, the first step might be oral agents like metformin or glyburide. But if those don't get the blood sugar to target or if we need really tight control, which we usually do in pregnancy, then insulin therapy is the way to go.
Why insulin specifically?
Because it's the most reliable. It gives the tightest control, and crucially, it doesn't cross the placenta. So it treats the mother without directly affecting the baby's insulin levels.
You keep saying tight control, we need the numbers. What are those specific targets everyone's aiming for?
Okay, for the self-monitoring people do at home, the fasting glucose target first thing in the morning is usually under 95 mg GDL.
Under 95 fasting. Got it.
And then after meals, the targets are either 1 hour post-meal under 140 mg GDL or 2 hours post-meal under 120 mg GDL. Different providers use one or the other.
Okay. 95 fasting, 140 at 1 hour, or 120 at 2 hours. Those are key.
Absolutely key. Meeting those targets is the main goal of management.
Let's link this back. Why push so hard for those numbers? What happens to the baby if the mother's sugar stays high? Connect it back to that fetal hyperinsulinemia.
Right. The risks are pretty significant. The constant exposure to high glucose makes the fetal pancreas produce all that extra insulin.
And insulin acts like a growth hormone, right?
Exactly. So it leads to macrosomia, a large baby, excessive birth weight.
Which sounds like it could cause problems during delivery.
It does. It directly increases the risk of shoulder dystocia, which is a serious emergency where the baby's shoulder gets stuck behind the mother's pubic bone during birth.
Oof, okay. And the high insulin itself causes issues after birth, too.
Yes, that's the rebound effect.
Yeah.
That baby's pancreas is used to pumping out massive amounts of insulin.
Because of all the sugar it was getting.
Right. Then the cord is cut, the sugar supply from mom stops instantly, but the baby's pancreas doesn't get the memo right away.
Oh, no.
It keeps overproducing insulin. And with no incoming sugar, the baby's blood sugar plummets. That's neonatal hypoglycemia. It can be very dangerous.
Wow, okay. And I read something surprising. High insulin affects the baby's lungs.
Yeah, it's true. High fetal insulin actually interferes with the production of surfactant.
Surfactant, that's the stuff that keeps the air sacs in the lungs open.
That's the one. So interference means a higher risk of respiratory distress syndrome, or RDS, in the newborn. And looking longer term, GDM exposure also increases the child's risk for obesity and type 2 diabetes later in life.
It really casts a long shadow. What about risks for the mother herself? Beyond needing a C-section, maybe?
Well, there's an increased risk of preeclampsia, that serious blood pressure disorder in pregnancy.
Okay.
Also, polyhydramnios, too much amniotic fluid. That
Yeah.
often happens because the hyperglycemic baby pees more, trying to get rid of the extra sugar and fluid.
And the biggest long-term risk for her.
The big one is her own future health. A GDM diagnosis is a major warning sign. She has a significantly increased risk of developing type 2 diabetes later in life.
Permanently increase.
Yes. And also a higher risk of having GDM again in future pregnancies. It's like her metabolic system was stress tested and showed a vulnerability.
Okay, let's talk about the final hurdle, labor and delivery. Even if things were well controlled during pregnancy, it sounds like vigilance is crucial right up to the end.
Oh, absolutely. If anything, the control needs to be even tighter during labor.
Tighter, how so?
Maternal blood glucose needs checking really frequently, maybe every 1 or 2 hours. And the target range is super narrow, 70 to 110 mg/GDL.
70 to 110, why so strict right then?
It's all about preventing that neonatal hypoglycemia, keeping the mother's sugar stable, and in that tight range right before delivery, minimizes the shock to the baby's system when the cord is cut.
So what do they do if her sugar goes out of that 70-110 range during labor?
If it starts creeping up above 110, they'll often use an IV insulin drip. Very precise.
And if it drops too low, say below 70?
Then they might give IV fluids containing dextrose, usually D5, which is 5% dextrose, especially if she's fasting. You have to prevent lows in the mom to prevent lows in the baby. It's a balancing act.
And if that shoulder dystocia risk we talked about actually happens, is there a specific procedure?
Yes, there's a common maneuver called the McRoberts maneuver.
McRoberts, what does that involve?
It involves flexing the mother's thighs sharply up towards her abdomen. This helps rotate the pelvis slightly and can widen the pelvic outlet, hopefully freeing the baby's stuck shoulder.
Okay. Wow. We've covered a lot. From those surprisingly powerful placental hormones
Yeah, initially designed to help the fetus.
to the pancreas not keeping up, the diagnosis, the targets, the risks.
And those specialized delivery room steps, it gives you the essential framework, hopefully.
I think so. The key takeaways seem to be GDM is when that normal insulin resistance goes into overdrive.
Driven by placental hormones, yeah.
Remembering those targets is vital. Under 95 fasting, maybe under 140 or 120 post-meal, and that super tight 70-110 during labor.
And understanding that fetal hyperinsulinemia explains so many of the complications for the baby. Macrosomia, the hypoglycemia risk, even the RDS link.
Okay, as we finish this deep dive, here's something to think about. We said the mother's insulin resistance drops almost instantly after the placenta is delivered. Her sugar often normalizes right away.
Right, the main hormonal driver is gone.
So, if the immediate problem resolves so quickly, why does that episode of GDM leave her with a permanent, lifelong increased risk for type 2 diabetes? What underlying change happened during those months that her body doesn't entirely forget?
That's a great question. What's the lasting impact?
Something for you to mull over. What metabolic echo remains?